guys, so today we're going to talk about nursing care of the child with a cardiovascular disorder. So we finally got past the congenital heart disease. That's long, right? There's a lot of it. Just focus on cyanotic versus acyanotic, obstructive disorders, and mixed. You're going to see a lot of the same symptoms, the same in a lot of different patients, that it depends on the severity of the whole or the narrowing. So in acquired cardiovascular disorders, this is something that they have had happen. They were not born with heart failure. They might have been born with a congenital heart disease that led to heart failure, but they were not born with heart failure. Heart failure is the heart's inability to pump effectively. So we want to give supportive care. We want to position these kids in an appropriate manner to be able to oxygenate effectively up high. We need to suction them in an effective way. We need to moisten the nasal cavities and keep them moist. We need to make sure the oxygen they're receiving is humidified. We need to break up all the mucus that's living in their chest. The suctioning helps to get that out, but we need to suction them before they eat so they're not going to vomit up their food because of the suctioning, and so that they have some energy and airflow to be able to tolerate feeding. We want to support their cardiac function. If you're giving DIG, obviously you have to monitor their heart rate. If you're giving ACE inhibitors, we're going to monitor that blood pressure, and we're going to hold the med based on the doctor's parameters that are in the order. We're going to weigh these kids daily because they are going to be at high risk for fluid overload, simply based on heart failure. We're going to monitor their potassium levels. We're going to make sure they're taking in good calories, not 75 bags of Takis, but good high protein, effective meals. We also want to limit activities based on their energy level to promote rest. So if you have a school-age child that's stuck in bed, or even a toddler, because they don't have energy and they need to rest to heal, give them art projects, sit in there with them and play a game, read them a book. They need something besides TV. All right, acute rheumatic fever is an acquired cardiovascular disorder. This kid got group A strep pharyngitis at some point, and then a couple of weeks later, when they're feeling really good, they have some other stuff going on. Either they've developed two of the major criteria that you see in that box, or one of the major criteria and two minor criteria. They're going to use that criteria, the modified Jones criteria, to determine whether or not this child actually has a rheumatic fever. They're also going to do a throat culture. This is a self-limiting disease, meaning that 6 to 12 weeks after the attack has started, and it is an inflammation, a progressive inflammatory response. 6 to 12 weeks after it starts, it's usually resolved and they don't really have any issues after that, but it can cause damage to the heart and the valves. So we do echocardiograms. We give them penicillin for a long time so that they can not get a strep infection again in the next 5 years. Look at that. Monthly penicillin for 5 years. Wow. They get penicillin therapy, corticosteroids, and NSAIDs. All of this is to decrease the inflammation. All right, so Kawasaki's disease, it's acute systemic vasculitis, which means the vessels all over are inflamed, we can have some serious cardiovascular issues. They can develop some problems with their coronary arteries. So I see a lot of these kids. It is more frequent in the winter and the spring, and they believe that is because it is related to some viral illnesses, normal childhood viruses. So our therapeutic management, we want to reduce inflammation in the coronary arteries to prevent blood clots. So we give them IVIG and aspirin, high dose aspirin every day, multiple doses. This is a type of an autoimmune disease. There is inflammation and swelling. These kids will come into the hospital usually 2 days into a really high fever, and the doctors will give them broad empiric antibiotic therapy, and they don't respond. And by the 4th day, you notice that they're still having really high fevers. So this is when you want to try to talk to the doctors about checking them for the constellation of symptoms that you might see in Kawasaki's disease, to narrow it down and maybe get them started on IVIG and aspirin. This is going to decrease their cardiac involvement over time. We want to try to keep these kids comfortable. We want to educate the family. We want to let them know these kids are miserable. They're going to get a little better, and the treatment is going to hopefully keep them from developing coronary artery disease in the long term.